Hello, my name is Brian Nichols, and I'd like to welcome you to Nursing 610, Pathophysiology and Pharmacology for the Nurse Educator. You've had a chance to look over your syllabus, and so one of the things you've noticed is that we really want to give you a deeper understanding of the pathogenesis of disease and also the therapeutic intervention and management of those diseases. We're going to give you a chance to take the pathophysiology and pharmacology that you've learned in the past, along with your bedside nursing practice, and really take a deeper look at what's happening to these individuals at the cellular and also systems level. And so over the course of the term, you'll have some opportunities to, assess your learning. And so one of the things that you're going to have is 5 modules. These 5 modules are designed to review information, but also introduce new information, and then give you a chance to try to really hardwire that information. Another thing that you're going to be assessed on is case studies. And so with the clinical case studies, what we're looking at is we're looking at patients coming in, usually to the ED. You're given a set of vitals, you're given their serum metabolic panels, and you're making determinations of what is going on with these patients, what are the deeper things that are happening. And so you'll have to assess not just the patient, but also the panels to determine what is your course of therapeutic intervention. Once you've made a determination on that and posted, then you'll be able to get the second panels and third panels that really will determine if you've made the right decisions or if you need to maybe make some corrective action in your decisions to really determine what the outcome of this might be for this patient. You'll also be so along with the modules, the case studies, you'll also have a final exam in this class, and it'll be pretty broad-based in general, but it's just kind of applying the information you've learned over the course of the term. And then finally, there's going to be a signature assignment where you will design a teaching for, as if you were going to be teaching maybe a second-year nursing cohort. And you're talking about a specific disease, you're looking at detailed, you're going down and looking kind of at the cellular level and tissue level, what's causing this disease state, and then what your therapeutic intervention in order to manage this disease state. So really what we want to do is to give you an opportunity to really take your past things that you've learned and really go deeper in them into those situations as a nurse educator. So I wanted to give you an example to begin with. So we're just going to start with a simple example, look at some physiology that you're familiar with from your physiology courses, and then also your pathophysiology. And then we want to look at 2 different disease states and then also the pharmacological management of those disease states. So just a simple example to begin with, we've got endothelial cells. So what I'm going to do is I'm just going to draw these endothelial cells. So this is my blood vessel. So we've got blood circulating through here. And then, of course, with endothelial cells, what you have is you've got vascular smooth muscle. And vascular smooth muscle controls the contraction of these endothelial cells. And so if these vascular smooth muscle cells contract, I'm going to get vasoconstriction. If they relax, I'm going to get vasodilation. And so those things are going to affect my blood pressure. So what I got up here is I have a adrenergic fiber. The adrenergic fiber will release norepinephrine. And so norepinephrine is released from these adrenergic sympathetic fibers. And what it'll do is it'll plug into a receptor on the vascular smooth muscle, and this is an alpha-1 receptor. When norepinephrine plugs into an alpha-1 receptor, it activates a GQ protein. The activation of the GQ protein activates PLC. PLC will activate IP3. IP3 will activate the sarcoplasmic reticulum to release calcium. So now I have calcium released. Now there's another pathway that I'm not going to put on here, but you activate DAG, which activates phosphokinase C, which then phosphorylates the opening of these L-type calcium channels. So now I've got calcium coming in from the sarcoplasmic reticulum. I have calcium coming in from the external environment. Now, if you remember back from your physiology when you looked at smooth muscle contraction, once calcium comes in, what's going to take place is I'm going to get contraction because calcium will bind with calmodulin, and calcium plus calmodulin will activate myosin light chain kinase. Myosin light chain kinase now becomes active, and that's going to split ATP into ADP plus phosphate. What I'm going to do is I'm going to give that phosphate to myosin, and myosin plus phosphate gives me contraction. All right. So when we have an increased sympathetic response, again, norepinephrine's plugging to the alpha-1 receptor, and it ends up causing contraction. Now, in the vascular system, we have something that actually opposes that because we have vasoconstrictors, but we also have vasodilators. One of your primary vasodilators is actually just nitric oxide. And so what's going to happen is just the sheer force of blood. So as blood flows through the vessel, just that force across the surface is enough to stimulate what's called CNOS. It's also called ENOS. ENOS stands for endothelial. So CNOS and ENOS are the same thing. So ENOS would be endothelial-derived nitric oxide synthase. And so when I produce this, what I'm going to get is I'm going to get NO, nitric oxide. That's going to diffuse into the cell. And when it diffuses in the cell, it's going to increase my cyclic GMP levels. So here I have an increase in cyclic GMP. Now cyclic GMP, what it does is it inactivates myosin light chain kinase, and it also activates myosin light chain phosphatase. Myosin light chain phosphatase will remove phosphate from my myosin, and it'll stop the contraction. So these two things kind of oppose each other. So let's look at two different disease states. The first one we look at is hypertension. So a lot of our patients have hypertension. And so when we look at hypertension, we look at blood pressures. And so blood pressure equals stroke volume times heart rate times peripheral resistance. Now, when we give them our beta blockers and our calcium channel blockers, a lot of those have effects right here because our beta blockers are going to block beta-1 receptors on the SA node and affect heart rate, and on the cardiac myocytes to affect stroke volume. So that will decrease here. But we also have peripheral vasculature medications that we can give. Now, if we're going to give something that blocks the alpha-1 receptor, we're going to give a thing called an adrenergic antagonist. Adrenergic antagonists are also called sympatholytics. So adrenergic antagonist to oppose, it's opposing the adrenergic release. Sympatholytic means to break. And so what it's doing is it's actually breaking this effect. So the one that you're probably familiar with is one called prazosin. And so prazosin is also called mini-press. And so some of you have given mini-press on the floor. And so what it's doing is it's going here and it's blocking norepinephrine. And so that causes the vasodilation, and that decreases the peripheral resistance. And now as I start to decrease your peripheral resistance, then what happens is your blood pressure starts to drop. Another one you can give is what's called nifedipine. And nifedipine, it's a calcium channel blocker. So nifedipine will block the L-type calcium channel here. So now I've got my sympatholytic, prazosin. I have my nifedipine that blocks here the calcium channel blocker. But another one that you might be familiar with is you might have standing orders that if a patient's blood pressure, the systolic blood pressure, greater than 160 or greater than 170, you give hydralazine. And so hydralazine is an interesting drug because when you give hydralazine, what you're doing is you're decreasing peripheral resistance, but it's given for systolic blood pressure, which means it's also decreasing stroke volume, but it's taking place here. So the proposed mechanism of hydralazine is that when I give hydralazine by hydralazine push, hydralazine goes in and it stimulates the increased production of cyclic GMP. As I increase cyclic GMP, it inactivates myosin light chain kinase, it activates myosin light chain phosphatase, removes the phosphate from the myosin, and I get relaxation. The reason it drops systolic blood pressure is because if you remember Frank Starling's law, the more blood you have in the ventricle, the stronger the contraction. Well, this actually decreases the mean arterial pressure, so I can push more blood out. Now I have less blood in the ventricle, and so my stroke volume will go down. So I'm decreasing my blood pressure here and then also here. So that's an example of hypertension, looking at the drugs that we use to manage that. And then we're going to go more in detail in this stuff later. So another type of situation is where you have shock. And so if I have shock, what's taking place is I've got a situation where my volume, my intravascular volume is going to the extravascular space, and then also my peripheral resistance is decreasing. It's kind of like this. You've got 5 liters of blood, okay? And those 5 liters of blood are in a 5-liter bucket. However, when you have shock, what happens is the volume goes down and the bucket gets bigger. So now I might have 4 liters of blood in a 6-liter bucket. So as you can imagine, what's taking place is instead of a hypertensive state, you're in a severe hypotensive state, and your blood pressure is dropping. So let's just look a little bit at the pathophysiology of that, and then also talk about the pharmacological management of that. So the pathophysiology of shock usually involves, well, there's different types, but one of the things we're looking at this term is going to be sepsis. And so with sepsis, what we have is we have activation of an inflammatory cascade. And so you're familiar with histamine, because histamine is produced by mast cells. And so when we get these chemical triggers that stimulate the release of histamine from the mast cells, I've got histamine. What histamine will do is it'll actually plug into H1 receptors on endothelial cells. Now, when it plugs into H1 receptors, a couple things are going to happen. One is I'm going to open these calcium channels, and calcium is going to come in. When calcium comes in, what's going to take place is these endothelial cells are actually going to contract away from each other. And so what's happening is calcium comes in, these endothelial cells contract, and because of that contraction right here, I have this increase in the intercellular or intercellular access. So the intercellular clefts between the cells have gotten bigger. So that would be the bucket getting bigger. So all of a sudden the bucket got bigger and my pressure's dropped. But the other thing that's taking place is I have an oncotic pressure of the capillary, and these proteins in here that are actually pulling fluid out are actually now increasing the oncotic pressure of the interstitial fluid. And so now I'm pulling less fluid back in, so I'm dropping the volume of my bucket. So one of the things that you need to do right away is you have to use a different agent now, because now what we want to use is not a sympatholytic, but a sympathomimetic. And so these sympathomimetic agents, what they're going to do is they're going to actually mimic the effect. And so one of the things you'll do with shock is you'll put your patient on a norepinephrine drip. And so Levophed is one of those agents that you can put them on a drip, and what it does is it goes in and it activates these receptors, and what you're doing is you're fighting against this. One last thing, when calcium comes in, what calcium does is it also activates inducible nitric oxide synthase. Inducible nitric oxide synthase will actually produce nitric oxide. And so nitric oxide diffuses over here into the cell, and just like the eNOS that's produced because of the shear force of blood, inducible nitric oxide synthase will really increase the production of nitric oxide. So now I'm increasing my cyclic GMP. My cyclic GMP is inactivating myosin light chain kinase. I'm knocking the phosphate off the myosin because of the activation of the myosin light chain phosphatase. And so now I've got my full scope of what's taking place. My fluids leaking out had dropped the volume in the bucket, but now because of the relaxation, my bucket is getting bigger. And so now my blood pressure is dropping precipitously. I'm in a hypotensive state. So once again, what we're going to do is we're going to intervene in that, and we're going to put them on either a dopamine, dobutamine, or epinephrine drip, and that is going to cause the vasoconstriction. The other thing you can do, so now I'm taking my peripheral resistance that was dropping because of iNOS activation, because of histamine, and then nitric oxide, and then finally the cyclic GMP, and I'm pushing it this direction because now, because of norepinephrine, I'm trying to get the activation of these alpha-1 receptors. And then, of course, also norepinephrine acts on the beta-1 and receptors, so I'm going to increase my stroke volume and heart rate. And then one of the last things you can do is give them some type of colloidal like albumin in order to compensate for the loss of protein into the endovascular space. So this was just meant to be kind of a preview of what we want to do. We want to look at these states and go, what's happening at the cellular level? Because if we can understand what's happening at the cellular level, we can actually know the trends, where our patients are trending towards. So if I have a patient and I'm watching this unfold and I'm thinking, gosh, man, I wonder if they're going into sepsis, or I wonder if they're trending this way. If I have an understanding of what's happening at a cellular level, I can actually kind of think forward and go, okay, what am I looking for next, and what do I need to do to manage this? And if I'm calling the physician, I want a certain set of orders to address what I think is impending. So anyway, hope this doesn't scare you. Anyway, we're going to be breaking it down for you over the course of the term. All right.